Discussing about the X-ray of the pleural effusion. The patient is having pleural effusion, that is accumulation of excess fluid in the pleural cavity, as the lung is lined by the visceral and the parietal pleura, and there is gap between the visceral and the parietal pleura, that is the pleural cavity. Normally 10 to 15 ml of fluid is present in this pleural cavity, but if there is excess fluid in this pleural cavity, that is the pleural effusion. So if the patient is having pleural effusion, what can you see in the X-ray of the patient is that the patient is having blunting of the costophrenic angle. So what is costophrenic angle? So this, you look on the right normal side, there is angle formed between the thoracic cage as well as the diaphragm. So this angle is the costophrenic angle. This angle is the costophrenic angle, and normally it is black. Normally it is black, or normally it is a radiolucent area. But here can you see that this angle on the left side, it is white, that so there is a blunting of the costophrenic angle on the left side. So the patient is having blunting of the costophrenic angle. So if the patient of pleural effusion is having blunting of costophrenic angle, there is homogeneous opacity. The opacity is a homogeneous opacity. So the homogeneous opacity, or you can say the homogeneous means uniform, there is no air bronchogram. The homogeneous opacity which is blunting the costophrenic angle, the homogeneous opacity which is blunting the costophrenic angle, suggestive of pleural effusion. The patient is also having meniscal sign. What is meniscal sign? Meniscus sign. So we know there is a meniscus in the knee. This sign is also resembling the meniscus which is present in the knee joint. Can you see there is a line here? There is a line here. So this is the meniscal sign. You can appreciate in another image if I show you the meniscus sign. So can you see the patient is having a meniscal sign here? Can you see the patient is having an S-shaped sign which is resembling the meniscus present in the knee joint? That is the meniscal sign. There is blunting of the costophrenic angle. Normally the angle is clear on the right side. Can you see on the left side there is blunting of the homogeneous opacity which is blunting the costophrenic angle, and the meniscal sign is present, is suggestive of left-sided pleural effusion. So the patient is having left-sided pleural effusion. The patient might also have shifting of the trachea to the opposite side. If the pleural effusion is massive, when you say that the pleural effusion is massive, if it is reaching up to the second rib, if the effusion is reaching up to the second rib, then we can say that the patient is having a massive pleural effusion. So if the patient is having massive pleural effusion, sometimes moderate pleural effusion also, there might be shifting of the trachea on the opposite side. Can you see that this trachea is shifted to the other side? The patient is having effusion on the right side, trachea is shifted on the left side. Effusion on the right side, the trachea is shifted on the left side. So the patient might have sometime shifting of trachea. So how you describe this X-ray? You describe this X-ray that there is homogeneous opacity which is blunting the costophrenic angle on the right side. The homogeneous opacity is expanding up to the second rib. There is shifting of the trachea on the opposite side, that is the left side. It is suggestive of right-sided massive pleural effusion. It is right-sided massive. Why massive? Because it is reaching up to the second rib. Sometimes you may not always get to see the meniscal sign. If the pleural effusion is massive, you are not going to see the meniscal sign. So what is this? We have discussed this is not pleural effusion. Can you see the trachea is still in the midline? So this might be a case of consolidation only. We have discussed this image. So in this image you can see again the trachea is shifted on the opposite side. There is massive homogeneous opacity blunting the costophrenic angle on the right side, suggestive of right-sided pleural effusion. What causes pleural effusion? The patient, or what you may be asked, what are the cause of the pleural effusion? Pleural effusion can be either transudative or exudative. So when you are asked about the cause of the pleural effusion, you should answer in the way I am writing, that the pleural effusion can be transudative or it can be exudative. You may be asked that how to differentiate between transudative and exudative pleural effusion. We use the Light's criteria to differentiate between transudative and exudative pleural effusion. The Light's criteria for differentiating transudative and exudative pleural effusion. We draw the pleural fluid, we send to the lab for examination of the pleural fluid, and if the pleural fluid protein by serum protein ratio is more than 0.5, then the fluid is exudative fluid, If the pleural fluid LDH by serum LDH, we will check for both the serum LDH as well as the pleural fluid LDH level, and if the ratio comes out to be more than 0.6, then the fluid is a exudative fluid, or the pleural fluid is an exudative fluid. Or we check for the serum or the pleural fluid, we check for the, if the pleural fluid LDH level is more than 2/3 of the upper limit of normal serum LDH. So if the pleural fluid level is more than 2/3 of the upper limit of normal serum LDH, pleural fluid LDH. So remember, pleural fluid protein by serum protein ratio more than 0.5, pleural fluid LDH by serum LDH ratio more than 0.6, or pleural fluid LDH level more than 2/3 of the upper limit of normal. If any one, not all, if any one of these criteria is fulfilling, then the patient is having an exudative pleural effusion. What are the cause of the exudative pleural effusion? The patient might having infection either because of bacteria, that can be TB, that can be staph, that can be strepto. Patient might having infection because of fungus, patient might having infection because of parasite. So infection is the cause of exudative pleural effusion. The patient might also having malignancy. So in case of malignancy, in case of connective tissue disorder like SLE, RA, Sjogren disease, the patient have exudative pleural effusion. Or if any of these criteria is not fulfilling, the pleural fluid protein by serum protein ratio is less than 0.5, LDH is less than 0.6, and the pleural fluid LDH level is less than 2/3 of the upper limit of normal. If all are less, then we say that the pleural fluid is a transudative fluid. The cause of transudative pleural effusion is congestive cardiac failure. Patient might have nephrotic syndrome, generalized swelling of the body, collection of ascites as well as pleural fluid also. So the patient of nephrotic syndrome having pleural fluid, that pleural fluid will be a transudative pleural fluid. So the patient of nephrotic syndrome will have a transudative. The patient of hypothyroidism is having myxedema. The patient is having a transudative pleural fluid. The patient of liver cirrhosis having ascites, and that ascitic fluid is reaching the lung, cause pleural effusion, then the patient of liver cirrhosis. will have transudative pleural effusion. The patient is having pleural effusion because of hypoproteinemia, any cause of hypoproteinemia, the patient will have a transudative pleural effusion. So if you are asked that what are the causes of pleural effusion, it is better to say that the causes of pleural effusion can be divided into transudative and exudative cause by using the Light's criteria. The Light's criteria is pleural fluid by serum protein by pleural fluid protein ratio that should be more than 0.5. If it is more than 0.5, then it is an exudative. LDH ratio more than 0.6 or LDH more than 2/3 of the upper limit of normal, that is exudative. The causes of exudative are infection. Exudative means it is a protein rich fluid. Exudative fluid is a protein rich fluid, LDH rich fluid. So the causes of exudative pleural effusion are malignancy, infection, SLE, rheumatoid arthritis and other connective tissue disorder. It can be also caused, or the causes of transudative pleural effusion are congestive cardiac failure, nephrotic syndrome, liver cirrhosis, mixed edema, any cause of hypoproteinemia. Any cause of hypoproteinemia. You may be asked about the ADA value. So ADA is specific for diagnosis of tuberculosis. What is ADA? ADA is adenosine deaminase enzyme, and we check this ADA level in the pleural fluid, and if it is more than 50 unit per liter, more than 50 units per liter in the pleural fluid, then it is suggestive of tubercular pleural effusion. The most common cause of pleural effusion in our setting is a tubercular pleural effusion. So we check for the LDA level of the pleural fluid. We take out the pleural fluid, we send it to the lab for checking ADA level, and if the ADA level comes out to be more than 50 unit per international per liter, then it is more suggestive that the pleural fluid which is accumulating in the patient is most likely because of tuberculosis, and we start the patient on anti-tubercular therapy. So this is about the ADA level. Now let us discuss about the miliary mottling. Can you see this X-ray and describe what is this X-ray? This is an X-ray which is showing miliary mottling. How to identify? Can you see a small discrete nodule of around 1 to 5 millimeter, which is dispersed in both the lung parenchyma bilaterally, symmetrically. So you have to mention that this X-ray is showing a small, discrete, well-defined nodule of 1 to 5 millimeter, which is dispersed bilaterally, symmetrically in all the lung zones. It is suggestive of miliary mottling X-ray. Most common cause of miliary mottling in our setting is tuberculosis. Can you see this X-ray of miliary mottling? Miliary mottling, small discrete nodule which is dispersed bilaterally, symmetrically in bilateral lung field about 1 to 2 millimeter in diameter. So that is miliary mottling. The causes of miliary mottling, or the most common causes in our setting, is tuberculosis. It can also occur in fungal infection like histoplasmosis. It can also occur in sarcoidosis. It can also occur in metastasis. It can also occur in Loeffler syndrome. Loeffler syndrome is because of parasite migrating in the lung, and the reaction to that parasite is the Loeffler syndrome. It can also occur in cryptococcuses. Very rare, not much. It's present in our setting. If the patient is having immunocompromised status, then only we suspect cryptococcuses in the patient. It can be cryptococcus meningitis or cryptococcus pneumonia in that patient. So these are the causes of miliary mottling or differential diagnosis of miliary mottling. So if you are provided with this X-ray, you define that tiny small nodule of 1 to 3 millimeter, which is dispersed in bilateral lung field symmetrically, suggestive of miliary mottling, provisional diagnosis, TB, miliary TB, differential diagnosis, histoplasmosis, cryptococcosis, sarcoidosis, Loeffler syndrome, metastasis. So this is about miliary mottling. Miliary mottling indicate that there is hematogenous spread of the infection. There is hematogenous spread of the tuberculosis. It indicates that the patient is having hematogenous disseminated tuberculosis if this miliary mottling is because of tuberculosis. Now let us discuss about the collapse. Collapse can be because of obstruction. So if the child or if the individual is inhaling something solid, that will get obstruct the bronchus, and distal to that bronchus there will be resorption or obstruction or resorption. And the lung will collapse So let's understand with the diagram. So this is your lung. Let's suppose this is your lung. So if the patient is aspirating something and that aspirated particle is getting stuck in the bronchus, distal to that bronchus there will be no movement of air. So this area, this obstructed area, the air which is present will absorb itself and this part of the lung will collapse. So one of the type of collapse is obstructive or resorptive collapse. Another way the lung can collapse is that, let's suppose there is a tumor. There is a tumor and that tumor is compressing this bronchus or a bronchiole, terminal bronchiole, and that tumor is compressing this bronchiole. Again, because of compression the air cannot pass in this area, and again whatever air present will be getting reabsorbed and the lung will collapse in this area. The second type of collapse will be because of compression. The third type of collapse can be because of fibrosis. So fibrosis is a type of collapse. Remember, if the patient is having infection and after infection there is fibrosis or fibrotic band formation, again there will be fibrosis and collapse. So collapse can be because of obstruction, it can be because of compression, or it can be because of fibrosis or cicatrization. So fibrosis or cicatrization usually occur because of infection. So if the collapse is because of obstruction and compression, you will get a homogeneous opacity. But if the collapse is because of fibrosis and cicatrization, you will get a linear fibrotic opacity. We will see the image, linear fibrotic opacity. So look at this image. What do you see here? You see that there is a homogeneous opacity. The trachea is pulled on the same side. Remember, when there is collapse, the collapsed lung will pull the trachea towards the same side. So can you see in this image that the trachea is pulled on this same side? There is crowding of the rib. When there is collapse, the rib will come together. There is crowding of the rib. Trachea is pulled on the same side. So it is a collapse of the lung. And this collapse is most likely because of mixed pathology. It can be because of obstruction as well as fibrosis. There is homogeneous opacity also, as well as you can see a linear fibrotic band also in this image. So never assume that only one mechanism is working. The patient might having different mechanism. Patient might having cicatrization also. The patient might having compression also. So there is collapse. Can you see this image? So there is an opacity, linear opacity, homogeneous opacity, which is pulling the trachea towards the same side. So the patient is having collapse. Look at this image. The patient is having homogeneous opacity as well as the trachea is full on the same side. The trachea is full on the same side. So the patient is having collapse. So how to explain collapse? There is homogeneous opacity, the trachea is full on the same side, there is linear fibrotic band visible. If present, you can mention this is suggestive of collapse. What will lead to collapse? The collapse can occur because of obstruction, foreign body aspiration. It can lead to compression. Tumor can cause compression and can cause collapse. It can be post-infectious. The fibrotic type of collapse can be because of infection, post-TB, post-pneumonia. The patient might have collapse. So these are the common X-rays you are going to get in your examination. For complete video on the clinical medicine, you can download the app from the Play Store, that is the Dr. Medrace app. In the Play Store it is available. You can download and watch the videos there. The complete series on history taking, examination, viva voice discussion, everything you can get in this app.